All right, good morning, everyone. My name is Dr. Tori Willard, and I am a psychologist in the Department of Psychology at St. Jude Children's Research Hospital. But for today, I am here as part of my role as member at large for research for the Hematology, Oncology, Blood, and Marrow Transplant Special Interest Group from the Society of Pediatric Psychology. And today I am very pleased to moderate our webinar on health-related stigma in pediatric sickle cell disease. As part of there we go. As part of our commemoration of Sickle Cell Disease and Childhood Cancer Awareness Month in the month of September, the HEMONC BMT SIG is running a series of webinars talking about different topics that are particularly relevant for our membership and the patients that we serve. Today's panelist is Dr. Lori Crosby. Dr. Crosby is a psychology at Cincinnati Children's. She is the co-director of the CCTST Community Engagement Corps. Today, she will be speaking to us about health-related stigma in sickle cell disease, and I will ask her to share her slides so that we can listen to her.
Thank you, Tori. Let me pull them up again. Now, there we go. All right, are you able to see that?
Yes, I am.
Okay, great. Thank you for the opportunity to present during Sickle Cell Awareness Month and Childhood Cancer Awareness Month. It is quite an honor. It's always an honor to do something for SPP. And I'm delighted to talk about a very timely subject. I'm going to talk about perceived racial bias, health-related stigma, and quality of life in pediatric sickle cell disease. The information that I'm presenting today is from a paper that recently was accepted, and we'll let you all know when it's published related to these issues, and then I'll be happy to answer some questions from our members about these topics. So this is my funding. I don't have any financial conflicts of interest for this particular presentation. I do need to give honor to my colleagues. The top three, Doctors Anna Hood, Avi Madi Swain, and Zena Trost. This is really a lot of their work that they collaborated with us and shared with us. And then there are other collaborators as well at Cincinnati and the University of Alabama, as well as Indiana University, Purdue University, who participated in this work. As always, I have to acknowledge that I learn constantly from the teams that I work with, both clinical and research, and from our patient and family partners. And as we get to the question and answer portion, a lot of that information will come from that work. So I'm going to talk a little bit today about health-related stigma in sickle cell disease, perceived racial bias, and then our study looking at the impact of these factors on health-related quality of life in children with sickle cell disease. I'll end by talking a little bit about what we think the study showed, and then some action steps that we as psychologists can take in the field. So just a little bit about sickle cell disease. Most of our membership is familiar with this, but just in case, it's a blood disorder. It's inherited, and it affects the red blood cells. And so most of the time, red blood cells are round and squishy and go through the vessels quite nicely. But in sickle cell, there is a hemoglobin that causes them to change shape. They become crescent, like crescent moons. They get sticky and hard, and they block blood flow, and that creates painful complications. And so it also creates the lack of oxygen and blood to different parts of the body and brain. In the United States, it's estimated that sickle cell occurs in every 1 in 365 African American births, and that it affects approximately 100,000 people. Also, 3 million people in the US are thought to have sickle cell trait. To have the disease, you have to have a parent who has, 2 parents who have some form of trait. Though sickle cell disease, we've come a long way with medical advances in treatment, and individuals are living longer, many continue to have poor access to quality care. And there are also a lack of treatments available, options available for this condition. And so as a result, individuals with sickle cell disease experience significant problems with pain, and they require frequent healthcare utilization due to the complications from that blocking of the blood flow, which may cause damage to organs or vessels in the body. So what is health-related stigma, and what do we really mean by that term? So health-related stigma can be defined as a form of devaluation, judgment, or social disqualification of individuals or populations who are identified with a particular health-related condition. So it really is a form of judgment against a person based on their health condition. What we know is that stigma from health conditions can result in guilt, shame, fear. It can lower self-esteem and dignity. And so really have an impact on mental health. In sickle cell disease, we know that stigma has been associated with individuals feeling lonely or isolated. Sometimes it's due to the physical limitations that they have from sickle cell disease. There may be issues related to their hips where they've had surgery and now walk with a limp. They may have other physical conditions from stroke or other issues. We know that complications and result in a lot of emergency room visits and hospitalizations that can reduce social interaction. And sometimes, especially for our adolescents, they get left out of things because they are sick. And so their friends stop calling them or asking them to do things. It's also possible that individuals with sickle cell disease lack support from healthcare providers at their school or workplace and within the community because there's still a significant lack of awareness about sickle cell disease in the larger community. In addition, we know that they experience discriminatory or disrespectful behavior from others in the healthcare system, but this also extends out into the community. And so what we know in adults is that studies of adults have shown that sickle cell disease, higher levels of stigma in sickle cell are associated with more depressive symptoms. Adults report stigma from the public, from medical providers, and even from their family members. One study found that patients who reported high levels of stigma were more likely to report increased fatigue, anger, anxiety, and depression compared to patients who reported lower levels of stigma. Although there was no difference in pain intensity, I think it's interesting that there was a difference in fatigue, which is a physical symptom as well. For adolescents, we know that adolescents with sickle cell disease report moderate to high levels of health-related stigma, and this has been found to be associated with negative health-related quality of life. So their overall functioning is lower when they report this health-related stigma. And higher stigma in this population, this subpopulation, has been associated with more loneliness, higher pain, interference, meaning the pain really interferes with more functioning, and less pain reduction in the hospital. So it may even affect their ability to recover. There's been less research done on children within sickle cell disease, but one longitudinal study did find that an intervention that focused on educational and communication skills increased levels of stigma for individuals with sickle cell disease. So as they were able to talk about it more and express more, they reported more stigma. So there's this complicated relationship between health-related stigma and health-related quality of life. And so we do need additional research because we don't think it's a one-to-one relationship where one leads directly to the others. We think there are moderators and mediators that impact what's happening. All right, sorry, hold on one second. Okay. Oh, oops. Okay, so stigma really has a larger context. And so what we know is the majority that this population of sickle cell disease, which in the US is primarily Black or African American or African, experiences systematic inequalities from the healthcare system. And this has been shown in a number of studies. For example, in the emergency department, we know that patients with sickle cell disease tend to wait longer than other patients. And this has been shown with a study where they looked at patients with long bone fractures seen by a physician, and even after accounting for race and assigned triage priority, they still waited 50% longer. We also know that pain complaints from patients with sickle cell disease have often been treated as false or discounted by medical professionals. In addition, we know that healthcare provider attitudes that there is discrimination, and it was really disease-based rather than race-based. And then medical providers' mistrust of the severity of pain reported by individuals with sickle cell disease is well known, and we believe that this also contributes to perceived health-related stigma among individuals with sickle cell disease. So we've talked a lot about health-related stigma and its impact on health-related quality of life in general and in adults, adolescents, and children with sickle cell disease. But what about perceived racial bias? Right now, this is a very timely topic in our society where people are trying to really understand racism and the systematic implications. And so what do we know about perceived racial bias in this particular population? So let's start by defining it. We perceive racial bias as indirect and rationalized negative attitudes that support that the other race is inferior. And so what we mean by that is it might not be openly or explicitly, but much more subtle. So indirect and more rationalized negative attitudes about a different race. So there are well-documented racial disparities in general for those patients seeking general pain treatment, but only a few studies have looked at this concept in patients with sickle cell disease. On average, we know that Black Americans are less likely to be prescribed pain medication to treat their pain, and that when they do receive it, they're prescribed lower doses than their white counterparts. And this, we think, is due to that racial bias. So what do we know about stigma and bias in sickle cell disease? So we know that health-related stigma experiences are further complicated, right, by racial bias experienced by the population. And this really comes out in the experience of pain. So youth with sickle cell disease endorse experiencing some racial bias within medical settings, and this has been associated with increased pain. In addition to stigma and higher pain, parents of patients with sickle cell disease have also reported experiencing more racial bias in the quality of care received than Black children with other chronic conditions such as asthma. And then one small study found that racial identity was not related to disease severity or hospitalizations, but lower public regard, so how they feel others view African Americans negatively, that was associated with their perspective that sickle cell disease, how they were treated as an individual with sickle cell disease. So there is some impact and some contribution of general racial bias on top of what's already happening in sickle cell disease. So previous research assessing the influence of health-related stigma and racial bias has identified challenges related to healthcare utilization, pain, and emotional distress. And the majority of research, of course, has been conducted on teenagers and adults and less on children. So in studies of children, the role of gender and health-related stigma and racial bias has really not been investigated often. It's not designed, or studies that have been designed haven't looked specifically at those characteristics. And the ones that are available are pilot studies. So they really don't have adequate power to detect differences between groups. So identifying this complex relationship between stigma and racial bias in younger children, such as middle childhood, and whether it differs for boys and girls would really help us to better understand the concept and develop interventions that might reduce stigma, impact perceived racial bias, and improve health-related quality of life. So in our study, we tried to understand the relationship between these concepts, health-related stigma and racial bias, and health-related quality of life in a sample of children with sickle cell disease. And we looked at also the impact of demographic factors, age and gender, to see if they were where they fit in these relationships. And we hypothesized that stigma and perceived racial bias would be negatively associated with health-related quality of life, and that it would be moderated by age, such that older children will report more health-related stigma and perceived racial bias. This study was conducted at the Children's Hospital of Alabama. Children had to be between the ages of 8 and 16 and have a diagnosis of sickle cell disease. They could not have a history of overt stroke, and they had to have a full-scale IQ of 70, either measured by the WISC-4 or the WASI-2. And parents or caregivers for this particular study were excluded if they were non-English speakers, as the survey instruments were only available in English. Participants completed paper-based questionnaires in a private room in the clinic over a 6-month period of time. 3 measures were given: the Childhood Stigma Scale, Perceptions of Racism in Children and Youth Scale, and the Pediatric Quality of Life Sickle Cell Disease module. We conducted Pearson correlations to assess the relationship between age and the measures. We looked at genotype because that sometimes is associated with disease severity, and so we wanted to see if that impacted as a covariate in this particular study. And then we did hierarchical linear regression models to determine whether these demographic factors, stigma and bias, predicted health-related quality of life. Here you can see our demographics for the mean age was about 11, with an age range from 8 to 16. It was primarily a male sample, but not that much, 57% to 43. Everyone reported that their race or ethnicity was African American or Black. You can see our genotype distribution there, with the primary of the children having hemoglobin SS, which is what we see typically in clinics. And then you can see the caregiver level of education listed there. What we found is that 40% of the sample reported poor levels of health-related quality of life, defined as scores on the PEDS-QL sickle cell disease module of greater than 60. 30% of the sample, so about a third, reported high levels of health-related stigma and perceived racial bias. And this is indicated by scores above the 70th percentile on those 2 measures. And so that's about a third of the children. Just take that in for a minute. A third of the children reported high levels of health-related stigma and perceived racial bias. These are middle school children. Older children generally reported better health-related quality of life, although it was not statistically significant. Health-related stigma was related to increased perceived racial bias, and then increased health-related stigma and perceived racial bias were related to poor or negative health-related quality of life. So we did find that relationship, as has been found in previous studies. When we looked at the modeling, we saw that health-related stigma predicted health-related quality of life, but age and gender were not significant predictors, nor were they significant predictors with perceived racial bias, which also predicted health-related quality of life. But our most interesting finding was this 3-way interaction between age, gender, and perceived racial bias. And what we found is that boys generally had higher health-related quality of life that did not differ as a function of racial bias or age. And older girls with high levels of perceived racial bias reported poorer health-related quality of life. So there were, of course, a number of limitations to this study. It was a single center, it was a small sample size. We did use surveys, and so we didn't use qualitative interviews, which might have brought out more of the emotions around racial bias and stigma. And so that would be something we would recommend in a future study. And then for some of these interviews, caregivers were, or some of the survey completion, caregivers were in the room, and so that could have impacted how the children answered. And then this was a number of our patients had chronic transfusions, and that subpopulation in sickle cell disease has been found to have poorer health-related quality of life in general, and so that could have also impacted our study results. So what we found is that children with sickle cell disease reported high levels of health-related stigma and perceived bias, and at least 30% of them. And this predicted poor health-related quality of life. Stigma seems to be perceived from a very young age. I mean, we had kids as young as 8 in the study. And this is similar to previous work assessing this concept in children in general. High levels of perceived racial bias had a strong negative influence on health-related quality of life for girls. And it could be this intersectionality between being Black and female in which the girls experienced specific forms of racial bias that males did not. And that could have, impacted our results and maybe what's going on for these girls. So in general, we would recommend, providers become more aware about the effects of health-related stigma and racial bias in children, and that they assess for these factors. What can we do? What actions can we take for the field, and next steps? If we could improve healthcare equity systematically and reduce delays in health services, that would be great, right? It would ultimately reduce that perceived racial bias, and we can talk more about that. But at a systems level, if we could change the way care was provided, and if we could think from a health equity lens, and what I mean by that is we often think of from an equality lens. So we say, oh, we'll provide this. So for example, we're going to assist with medication adherence, and we come up with one strategy for doing that instead of saying what would be multiple strategies. People may have different needs, different barriers, and so maybe our intervention looks different for different families because that's what they need. Some families might need more, some families might need less, and that's okay. That's more of an equity lens. And so hopefully we could do things like that to reduce delays in care. Community health workers are an intervention that's being tested right now specifically in sickle cell disease, and this has been found to be a great source of social support as well as support in navigating these complex healthcare systems. So that could really help with our access to care and with these more equitable approaches, because they could fill in some of the gaps in terms of getting families what they need to be more effective, and maybe help with mitigating some of that stigma. Medical providers can begin to take some action by getting more culturally relevant training in cultural humility, training in how to be anti-racist, training in other things that will help them to communicate more effectively with the population, and especially around these issues. And here I think there's a true role for psychologists, because we have a lot of training and expertise in those areas, and it would be a great opportunity for us to provide that training and support to our teams as we work with them. We need to really work on improving those patient-provider interactions. This is another area where I think with our expertise in communication skills and in health interventions that we can really provide some help to our medical colleagues. And then what the literature has shown is medical colleagues who attend workshops where patients share their stigmatizing experiences, there's been a significant improvement in their communication and their attitudes towards patients and families. And so I think, again, this is something that as psychologists, we can help to coordinate, organize, support, suggest to our teams. All right, I will end there, and then I'm happy to answer questions.
Wonderful. Thank you so much, Lori. That was a really lovely talk, and I know will be of great interest to our viewers. And so in advance of your talk, we had polled our membership for questions. They didn't have the specific talk, but just the general title. And so I will ask those now, and we'll see what we come up with.
Okay, sounds good.
The first question is, someone says, I'm always interested in the topic of addiction, both for the stigma towards it, as well as the real risk for some, especially those with many other risk factors. Could you speak a little bit about this?
Yeah, so this is definitely a problem for adolescents and young adults with sickle cell disease and adults. Put my little headphones.
Passionate about this question.
And so what we know in the literature, when they've done studies to look at addiction in this particular population, is that there's just the same amount as in the general population as in the sickle cell disease population who are addicted. So there's not any more prevalence or anything else in the sickle cell disease population. It's the same as the general population. And so we need to remember that when we're interacting with this population. They're not more likely to be addicted than anyone else. Do they have a higher tolerance for some of the medications? Yes, because they've been using some of these medications for years, but it doesn't mean that there is addiction present. And so I think that is an important thing for our membership to know and remember, and to educate our colleagues about.
Absolutely.
I don't know if that answers the question.
Yeah, that it's that perception that they're perhaps, or that bias that they're perhaps more likely to be addicted. But if we actually look at the research, they are no more likely than anyone else that walks into that ER. Absolutely. Thank you.
Correct.
Do you have any suggestions on how to engage this population more, as it is harder for me to reach as compared to my oncology caseload?
Yeah, I think what people do is they have to remember that this population, because of being stigmatized, because of being typically a diverse population in the U.S., there's been a lot of negative experiences. And so I think the population comes in being a little more hesitant, or a little, mistrustful. And there have been lots of experiences where things have been done to other Black populations or subpopulations of the Black population. And so people kind of have their radar up. And so they are a little bit harder to get to know. And so I think what's important is really focusing on the relationship, really listening, reflecting, and that curiosity, but not like prying curiosity, but more like, oh, what you said was very interesting to me. I'm going to ask a follow-up question because it was so interesting to me. Not like, I'm asking you really personal questions, but more just, that was interesting what you said, or I'm reflecting on the feeling that I think was behind what you said. I think that really is a better way to interact. And then again, I think remembering that every person has a story, and trying to figure out what that person's story is, right? And connecting on that level, instead of just, oh, this is a patient with da 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 da. That might describe 5 patients, but each of those 5 patients got there in a different way, and it comes out differently. And so how can you, as a provider, connect and think about those things? We have a couple of providers at our institution who came up with a guide to help during this time of social unrest, about how they could talk to their families about those issues and be supportive, and just certain words that would validate the experience and recognize that. And so I would say those things are important too. So if if we just had, unfortunately, the recent murder of another Black unarmed man by policemen, right? Jacob Blake. And so I think, talking about it in that way, the murder of, Jacob Blake or whatever, I think using those words are important to validate sort of the experience and what's happening. So I think showing your commitment and curiosity, trying to recognize the story, and then using words that are specific and validating are really helpful.
That is really lovely and ties very well to our next question, which is, as a white provider, what language can be used to really appropriately acknowledge differences and create that comfortable environment? And I think, as you said, words like using "he was murdered," is kind of shares that connection and that understanding of what happened in ways
And I
that
think when you're
different
when you're a
words
white
would not say. Yeah.
Right. And I think when you're a white provider, I mean, I think, saying if there's a difference, just saying as a white person, I might not fully understand, but I can appreciate that what I saw was traumatizing for me. So, I just know that, and I know it probably affected you in some way too. I don't know, exactly how, but just recognizing that and saying your limitations of what you understand and what you don't, I think is fine, and it's validating for the other person. What I think people don't like is sort of if you come at them and assume that you understand their full experience, right? So we know that anyway from being psychologists, that in our daily work, that's not a good idea, right? We want to say, how did that impact you? And you tell me how it affected you. I'm guessing it might have done this or this, but tell me. And then people fill in the blanks for us, right? It's the same type of thing. But I think recognizing that, the white experience in America might be different from the Black experience, and that's okay. It's just how it is. And just saying to them, I may not understand, but I want to, I would like to, and I would like to support you. And, let's talk about ways I could do that, or ways we could, things could work for you and your family.
Absolutely. Giving them ownership over their story and allowing us to learn from their story, whether it's related to their disease, whether it's related to their experiences as a Black person living in the current climate. But again, giving them that ownership over it's their story and it's their right to tell it. And it's our job as psychologists, whether we're white or Black, to listen and try and understand.
Right. And I think it's fine to use the words white and Black too. I think people get a little bit nervous about that. And sometimes I just always ask folks how do you identify, what do you consider to be your racial ethnic background? Because I don't know. So I have to ask, and I say, I ask because I care, because I feel like this may have had an impact on your experience in life. And that's what we're here to sort of talk about. And so that's the reason I'm asking. So I think if you use the words, tell them why you're asking, how it fits in with whatever else you're doing, whether it's an assessment or a consultation or an intervention, whatever you're there to do, just explaining to them why you're asking, allowing them to define themselves, not you defining them. And then I think those really make a huge difference too.
Absolutely. Thank you. So switching gears a little bit, what measures do you recommend using to accurately assess pain for patients with sickle cell, since the 0 to 10 scale does not really seem to accurately describe pain with the patients that I work with?
Right. I think, the 0 to 10 scale is hard for anybody,
For
right?
anyone,
Because an 8 for one person is not the same 8 for another person. So I think it's a good place of where to start. Is the person like defining their pain more on the severe end, the middle end, or the low end? That's kind of how I use the 0 to 10 scale. And then I look more at functioning, right? So I think the functional disability concept is the one to use, right? Like, what are you able to do? What are you not able to do? And how do we get you doing more of the things that you were able to do before you came into the hospital or before you had this pain crisis or whatever? Where are we on that scale? And so we really look at functioning, and when their functioning is higher, then we know that they're doing better. So we don't really look at much at pain numbers because they still might be an 8, but they might still be able to do more things than before. And that's okay. They can stay an 8, as long as, and then in sickle cell, pain is complicated because there is breakthrough pain. And so you sometimes get worried that people are not going to be on time with your pain medication, and you might get some of that breakthrough pain, and you don't want that. And so you know that if you say you're an 8, they're more likely to come on time and do whatever. And so you may have learned to give a certain number, or to, you know, express your pain in a certain way to get what you need. And I think that's a failure on our as a system, you know, that where we haven't done a good job as providers of assessing the whole person and the pain experience. And so I think as we do that, we see much less of that as well.
And then that stigma comes in too of, we know what those patients who are more savvy and are asking, say, I know that this works for me, then they become called drug seekers and worried about addiction, because you shouldn't know the name of your pain med. But if you're 25 and you've been having pain crises since you were 5, you should know the name of your pain med and your kind of cocktail that works best for you. That's part of being a patient advocate. But then, you know, it's that rock hard place where you get criticized for that as well. So
right, if you were a patient with diabetes and you knew all of your diabetes medicines and what worked, people would say, oh, you're great, you know all of that, and you know what works for you, and that's amazing, and all of that. But you don't get that same feedback from providers in sickle cell disease, because it's pain medicines.
Absolutely. That's a great comparison of other chronic illnesses where you get in trouble if you don't know your regimen, versus in sickle cell disease, you get in trouble if you do. So, all right. So one final question. How do you think that we can really better advocate for people living with sickle cell disease? And you talked about this a little with your action items, which were fantastic. But kind of how, as we as psychologists, as members of the Society of Pediatric Psychology, advocate for our patients?
So I think there are a couple of things I would suggest. One is we can help tell our patients' stories and get them to tell their stories. So anything we can do, if we make little videos and we show them to our providers, our team members, if we do other things, you know, that we see something at a conference, we bring it back and show it to folks, I think that really does help. So those stories really do help to sensitize providers. And when we get new providers, we might have to go a little bit out of our way to make sure that they have access to that information. So they really are understanding things from a different point. I think the second thing we can do is make sure that in our language, we're understanding and we're advocating and just, you know, helping providers realize about the impact of the social determinants of health, right? That these factors really do affect health, and they really do affect decisions. And sometimes telling a story or telling the journey of someone can really help the rest of the providers kind of come on board with, oh, I see. Oh, I didn't think about that. I hadn't realized that. And so just sensitizing providers, I think, to those issues. The third thing I think we can do is in our clinical work, I think really, again, validating our families, you know, and encouraging them to be advocates, you know, whether it's, you know, increasing their ability to manage their disease or advocate during sessions, during their clinic visits, you know, that's fantastic. So, you know, we in our clinic will say, like, you know, bring 3 questions that you want to ask providers, and we get a lot of reinforcement around that, right? And so now the providers are expecting these, you know, to be asked 3 questions. And so it's not like a, you know, as off-putting as it was probably in the beginning, but we're teaching them to be advocates. And so I think modeling that behavior and showing the providers how different and meaningful the conversations can be when you have those 3 questions versus just them sort of talking at the family about whatever topics they felt were important, but more, you know, really hitting on the ones the family is worried about or thinking about, and how much richer the conversation is and how deeper their relationship can go from there. So I think that's another thing we can do. And finally, I think in our research, I think that, you know, the way that we talk about the population, we can talk about the strengths, we can talk about advocacy, and really think that way as we're developing our studies, as we're reporting on our studies, really think about how can our research be used to advocate for the needs of this population.
Absolutely. Well, thank you so much. I think those were 4 great action items for all of us. I particularly like the 3 questions, so that those clinic visits really are more of a conversation and less of a lecture, which I think they sometimes end up being, and that those physicians have have learned to work that time into their time with a patient. And so to save that and make sure that that's a really important part where they can really be, those patients can communicate and learn to be their own advocates. So I really like that a lot. Well, thank you so much, Lori. We really appreciate you joining us today and giving this talk to our membership. And I will just share one final slide, hopefully.
Okay.
There's Lori's picture yet again. Yeah. We're trying to get to the next slide.
It does not want to go to the next slide.
It does not. Let's try this. Okay. Give me 1 second, guys. Sure.
No, it's been a great pleasure for me to be here today to really talk about this, and I hope that someone will be inspired to work with this population or persist in working with this population and to try to build some awareness in the community.
Yes. Well, here's my final slide. We'll do it the old-fashioned way, which is really thank you for joining us, and to put in a plug for our new SPP Hemonc BMT SIG Twitter account. If you are on Twitter and would like to join us, we'd love to have you. We have several other webinars that we will be posting throughout the month of September. And certainly once Dr. Crosby's paper has been officially published, we will make sure that we provide a link there as well for our followers. But again, thank you, Dr. Crosby, so much. And we look forward to continuing this conversation.
Okay, great. Thank you. Bye-bye, everyone.